I just have a brief announcement before we start. Somebody lost a $100 Visa gift card at one of the focus groups yesterday, so if anyone picked it up or sees it, just contact someone in the Oley staff and we'll make sure it gets into the right person's hands. So this brings us to the Hot Topics in Research, part of the main session. The NutriShare Home PN Research Prize, sponsored by NutriShare Incorporated, was established in 2007 to encourage clinical studies focused on improving the quality of life on home parenteral nutrition consumers. Each year, the Oley Foundation awards $2,500 for each of the top 3 clinical research papers that are best aligned with Oley's mission. Clinical research is awarded points for each of the following criteria: how much interest the research would generate, and how well the research fits with Oley's mission to enhance the lives of home parenteral nutrition patients. We'd like to thank our voting committee, which consists of consumers and professionals, Emma Tillman, a pediatric critical care pharmacy specialist at Riley Hospital for Children, Indiana University Health in Indiana, and an HPN consumer, Jerry Mayer, an HPN consumer, Dr. Ethan Mezoff, who's currently at the Nationwide Children's Hospital in Columbus, Ohio, Dr. Charlene Comfer, Associate Professor and Faculty Director at University of Pennsylvania, Dr. Lynn Howard, Medical Director and co-founder of the Oley Foundation, Dr. David Mercer, Professor of Surgery Transplant, University of Nebraska Medical Center, and NutriShare Incorporated. And again, thank you to NutriShare for your continued support. And I will now turn the program over to Dr. Darlene Kelly, who will announce the winners of the research prize.
Well, good morning, and I hope those out in the with the food will bring their food in here and go ahead and eat during this session. This session has been something that we've been doing for several years, as Andrea has already said, and it's because so much of what we do in home parenteral nutrition is widespread in terms of those who really need this research to do better each day. And so what you will find is that all 3 of these winners were multicenter trials, which is excellent. I think this is probably one of the best sets of research applicants and winners that we've had for forever, as far as I can tell. So at any rate, the first winner, we went by the first letter of the first name alphabetically. So the first one is to Dr. Beth Carter at one of the Texas Children's Hospitals in Houston. Is that Beth? Okay. Yes. All right. So in 2017, the NutriShare Home Parenteral Nutrition Research Prize is awarded to Beth Carter. Beth, come on out.
Okay, all right.
Part of the Baylor College of Medicine. And because these are multi-center trials, there are lots of authors. So I will quickly go through these authors. And I'm going to probably goof because I'm just going to say Dr. So-and-so, and a few of them are not doctor, but whatever. Beth, first of all, congratulations.
Thank you so much.
Yes. Beth and I were on a committee together, except it was not a face-to-face committee. It was all done by telephone, so I've never met her officially. So, hi, Beth. She is going to, you can stay up here. Okay, so the title of this paper is Outcomes from a 12-week open-label multi-center clinical trial of teduglutide in pediatric short bowel syndrome. And the multiple authors are doctors Beth Carter, Korson, Cole, Corkins, Dimmitt, Dugan, Hill, Horslund, Nichols, Sigurdsson, and Teitelbaum, and Thompson, Vanderpool, and Vaughn. Is that everybody? No, Yusuf, Venick, and Kokish. All right. And they're from, as I said, many different centers. So I don't have a list of where everyone's from, but I know some of them are from various locations in the country. So Beth, I think I'm probably giving you this at the end, but you know what? You can get it now. That's her award, along with a little financial contribution. So Beth, please tell us about this study.
Thank you so much. And thank you to the Oley Foundation for inviting me to present this paper on behalf of my colleagues. It's especially exciting for me to present in front of this audience of patients and caregivers because the clinical trial is really for you. And so it's a unique opportunity for me, so thank you all for coming. So let's begin with disclosures. I served as a study investigator for this study and received research support from the sponsors of this study, which were NPS Pharmaceuticals and Shire. And I've also served as a speaker for Thrive. So I don't think I need to talk to this audience and tell them that children with short bowel syndrome are often have diminished absorptive capacity, and they may remain parenteral support dependent for many months or even years with little intestinal adaptation under the current standards of care. Teduglutide is a GLP-2 analog, glucagon-like peptide 2. You may know, most of you in the audience, that this drug, teduglutide, was approved in the United States for adults with short bowel syndrome dependent on parenteral support in 2012. You may not know, however, that it was approved for children with short bowel syndrome aged greater than or equal to 1 year in the European Union. And in Europe, it's known as Revestive. Here in the United States, the brand name is Gattex. Teduglutide stimulates small bowel growth. And that's not a growth in the length of the bowel. Rather, it's a growth in the intestinal villi, which are the finger-like projections that extend into the lumen of the bowel and help to absorb nutrients and fluids efficiently. And in this way, this mediates intestinal adaptation in those that receive teduglutide. What I'm talking about today is the initial pediatric clinical study of teduglutide, and it was aimed to evaluate whether teduglutide enhances intestinal adaptation in parenteral support-dependent children with short bowel syndrome who have not had significant advance in their enteral nutrition. This slide is a schematic of the study design. What you can see is that there were 4 different cohorts in this study. 3 of them were treatment cohorts, and the one shown on the bottom here was a standard of care cohort that did not receive teduglutide during the study. The 3 different treatment cohorts received study at 3 different doses. The lowest dose was 0.0125 milligrams per kilogram per day subcutaneously for 12 weeks. The middle dose was 0.025 milligrams per kilogram per day for 12 weeks. And the high dose was 0.05 milligrams per kilogram per day subcutaneously daily for 12 weeks. The observation group did not receive medication, but they did come to study visits in a similar interval as the treatment cohorts, and they received the same nutritional and lab monitoring. All cohorts were screened for at least 2 weeks prior to study entry. They received medications at different doses sequentially for 12 weeks. At week 12, the medication stopped, and data was collected until week 16, at which time the study ended. Safety data were assessed after at least 28 days of teduglutide treatment before the next dosing cohort began. And as you can see, this was not a blinded study, so everyone involved in the study, patient, caregivers, investigators, we all knew which patients were receiving the medication and at what dose. So all patients in this study were aged 1 to 17 years with short bowel syndrome for greater than or equal to 12 months, and they needed to be on parenteral support for at least 30% of their caloric or fluid and electrolyte needs. They could not have had more than a 10% change in parenteral support or an advance in enteral nutrition feeds in the 3 months going into the study. Enteral nutrition calories and volume data in this study were based on commercially available liquid feeds taken orally or given via tube feeds only. So additional solid foods and liquids were considered ad lib nutrition and were not included in any of the calculations of enteral nutrition that you'll see today. The statistical analysis of this study was descriptive statistics. So what this means is you will today hear words like median, minimum, maximum, number of patients, and percentage of patients. These are some of the baseline characteristics of the study. 40 of 42 patients completed the study. 1 withdrew their consent, and another was withdrawn due to patient protocol noncompliance. And so this is a summary of some of the different characteristics of all different cohorts. And just to point out, you'll see their ages here. Looking at the duration of parenteral support dependency in years, you can see it was low as 6 months and high of 12 years on parenteral support. As far as median estimated residual small intestinal length in centimeters, there was a wide range. There was one patient that really just had a remnant of bowel all the way up to 145 centimeters. I'd like to just point out that this 145 centimeter patient happened to be my patient in the study, and I think this highlights the fact that the length of bowel does not necessarily predict parenteral support need, that it's also the function of the bowel that often is the determinant of how much parenteral support need is needed in a particular patient. Because by length, you would not predict this patient would need parenteral support at 30% or more of their calories. The median parenteral support volume at baseline in liters per week was as low as 4 liters, as high as about 16 liters. Median enteral nutrition volume at baseline in liters per week was as low as 0.3 liters per week and as high as 13.4. So those were some of the characteristics of the patients in this study. So now to get into the nitty-gritty details and some data. This is a graph that shows the decrease in parenteral support volume, and what it shows is the median weekly parenteral support volume change from baseline, from 0 to week 12. This is a bit of a busy slide, but I'd like you to focus on week 12. And what you see is that in the standard of care cohort and the low dose cohort, they had no change in parenteral support volume at week 12 compared to week 1 baseline. But what you do see is that the middle dose group and the high dose group had a 41% and a 25% decrease in parenteral support volume at week 12 compared to baseline. So these two groups showed that they decreased parenteral support needs during the 12-week study. What about decrease in parenteral support calories? Again, you see a similar graph here. Median weekly parenteral support calorie change from baseline in percentage. And again, a busy slide, but if you could focus here on week 12, what you see is that the standard of care group that did not receive the medication actually increased their parenteral support calories at week 12 compared to baseline. There was no change in parenteral support calories in the low dose group, whereas the middle and high dose groups had a decrease in parenteral support calories of 41% and 44.7% at week 12 compared to baseline. This is one of my favorite slides in this talk. And what it is showing is gain in time off parenteral support at week 12. And the reason I like this slide is that this is the slide that really gets at how this therapeutic really has potential to change the daily lives of patients who receive it. So in the categories looked at here are the change in hours per day of parenteral support infusion. And what you can see that the standard of care group and the low dose group did not have any change in hours per day, but the 0.025 milligram per kilogram per day group and the 0.05 treatment group had a decrease in 4 hours per day and 3 hours per day at week 12. How about patients who gained at least 3 days per week off of parenteral support? There were a total of 5 patients that achieved this, 1 from the middle dose group and 4 from the high dose group. And there were actually patients that completely achieved parenteral support independence during the study, 1 from the middle dose group, 3 from the high dose 0.05 milligram per kilogram per dose group. Now, it should be noted that 2 of these 4 patients resumed parenteral support 4 weeks after the teduglutide treatment ended, but 2 remained independent from parenteral support at week 16. What about advances in enteral nutrition volume? That is shown in the graph here. Median weekly enteral nutrition volume change from baseline expressed as a percentage. Again, I want you to focus here at week 12. And what you can see is that there were advances in enteral nutrition volume across all cohorts compared to baseline. And this was generally maintained or increased at week 16 when they were no longer on medication. Here you see advances in the enteral nutrition calories. Median weekly enteral nutrition calorie change from baseline expressed as a percentage. Again, focus on week 12 compared to baseline. There was an increase in enteral nutrition calories across all cohorts, and importantly, this was maintained or increased at week 16 when no longer receiving the medication. This slide shows you the nutritional status at baseline compared to week 12. There was clinical and nutritional status parameters that were maintained despite parenteral support reductions in the teduglutide middle dose and high dose groups. Albumin, blood urea nitrogen, creatinine, and electrolytes such as calcium, magnesium, and phosphate were stable at week 12 compared with baseline. And what you see here is some median weight data, baseline compared to week 12 in all 4 of the cohorts. And you can see that weight was maintained or increased at week 12 despite the decrease in the amount of parenteral support during the study. Let's go on to talk about safety or treatment emergent adverse events. The important thing to remember here is that any clinical study such as this needs to require that the investigators report any adverse events, whether or not they're related to the medication. And so you'll see those listed here. All patients experienced at least 1 treatment emergent adverse event, but most were mild or moderate, and you'll see them listed here. There are things like vomiting, upper respiratory tract infections, catheter complications, fevers, coughs, abdominal pain, headache, etc., diarrhea, central line infections. The most common treatment emergent adverse events in the teduglutide recipients was vomiting. But you can see that these adverse events occurred in both standard of care and the teduglutide recipients. Serious treatment emergent adverse events were experienced by patients in both the teduglutide and standard of care groups, but actually at a lower rate in the teduglutide groups. So 46% rate of treatment emergent adverse events in the teduglutide group compared to 60% in the standard of care group. Importantly, none were considered related to the study treatment. Also importantly, there were no reports of intestinal obstruction, fluid overload, biliary complications such as an inflamed gallbladder or pancreas, or signs and symptoms of colonic polyp formation. And no patients developed neutralizing antibodies to teduglutide, tongue twister. Neutralizing antibodies to teduglutide were not found in the study, but if they were, in theory, these are the type of antibodies that might ameliorate the response to the medication. So here you do see a list of these serious treatment emergent adverse events listed here: central line infection, fevers, catheter-related complications, and upper respiratory infections such as parainfluenza. And what you might notice is that most of the conditions listed here are conditions that are very common to short bowel syndrome patients in general. And so these could occur in patients whether or not they were on a clinical trial, whether or not they were receiving a study medication like teduglutide. So in conclusion, treatment with teduglutide in children whose intestinal rehabilitation had plateaued was associated with a decrease in parenteral support volume and calories and an increase in enteral nutrition volume. This was a study that looked at trends, and it appears that the high-dose teduglutide, 0.05 milligrams per kilogram per day, trended to have the most efficacy. This dose reduced parenteral support volume by 25% and calories by 45%. Patients in this cohort advanced enteral nutrition volume by 40% and calories by 62%. In this cohort, parenteral support independence was achieved by 20%, 3 out of 15 patients in this cohort. 27% of patients in this cohort gained at least 3 days per week off parenteral support. At 4 weeks after discontinuing teduglutide, enteral nutrition improvements were maintained, and 2 patients remained parenteral support independent. Teduglutide had a generally good safety profile and was well tolerated in this initial pediatric study. Clinical and nutritional status was maintained in teduglutide-treated patients despite reductions in parenteral support, suggesting improved intestinal adaptation. So I'd like to acknowledge the patients that were part of this study, the parents, the caregivers. It takes a whole team to make a clinical study like this work. In addition, all of the study investigators, this was a multi-center trial across 17 studies, mostly in the United States, 1 in the UK. And this was a team that worked immensely well together, and we do it for patients like you. So I'd like to take, if I have a moment, a few questions. If not, I am happy to answer questions at the breakout sessions later today. And thank you for your attention.
Thank you, Beth. Thank you. As the moderator for the session, I kind of have the first chance to ask her a question. And one thing that I noticed was that there were fairly large age range in these, and I also noticed that the weight increase was greatest in the lowest dose of teduglutide, if I read it right, which was kind of surprising, but I wonder if the ages were a complicating issue. For instance, you wouldn't expect an 18-year-old to gain the weight that a really young child did. So that was my only explanation I could come up with.
So I would agree that the age makes the weight data a little bit difficult to interpret. And so really, from this study, it's important to remember that we can't do the fancy statistics because there's confounders like the age and the ability to put on weight at a younger age versus an older age. But this was a very solid beginning step for the trial that gave us the trends to kind of go into the next step trial, which is ongoing right now, and I would love to talk about more in the breakout sessions, that helped us design the next step trials. So yes, we could really only take trends and not the numbers in this study, and the age range was confounders and limited us in doing the fancy statistics.
And I think the safety aspect of it was really the big point
Right,
here.
that was the big initial step.
Okay, so any other questions, Lynn? Do we have a microphone for her?
In the earlier adult studies, I think it was important to recognize that the biggest effect of the drug was on fluid balance and not on improved calorie intake. And it's intriguing that you found that especially after you'd stopped the drug, you still had people holding their own in terms of weight gain. And so I think it raises two questions, really. One is that you are looking at an individual who is maturing. And so the whole question of can you speed up that maturation is an issue with children, or are you just seeing children carry on what you'd expect to do? And therefore, the fact that it was a relatively small group and at different points in there leaves it very difficult to answer that question. Did you improve the rate at which they adapted? And the second question, which I think comes out of this and came out of the adult study too, is that the sustained improvement once you drop the drug, in one sense, makes no sense. This is a medication that causes a change which reverses when you stop. On the other hand, people learn from what they can do in the study, and it would seem as if that was an important component to these children's sustained improvement even off the drug.
Yeah.
Thank you.
May I just comment on that? I think your points are very well thought out and well taken. The data that I show on sustained weight, we need to remember that that was at week 16, okay? So the total study, treatment was 12 weeks, data out to 16 weeks. And so that's what I show you. I think, and I can speak to this in our small group sessions, I think there's variation when you extend it, these patients out further. I have a bit of experience with that because I had 5 or 6 patients in this initial trial, and I have some insight into what happens on the weeks later. Not everyone continues to have as good electrolyte and fluid balance past week 16 while off the drug. Some do better than others, but I can speak to that today in the sessions, and I think part of that is why the follow-up studies are designed for 6 months of treatment, so longer treatments. I think we're still trying to tease out the length that these children need the drug.
Is there one more question? I think that'll, oh, Lynn, go ahead.
Can I just make one other point? I think it's unfair to not make sure that the audience understands that you're dealing with a drug that stimulates growth. And any drug that stimulates growth could indeed stimulate inappropriate growth. And that becomes much more important in this population. So I don't know whether you were doing careful studies, probably not in such a short study, on the mucosa and so on, but it isn't obvious yet that it's totally safe. Thank you.
Comment?
Yeah, comment to that. That was a concern in the design of the study. If you can imagine, if a medication causes intestinal villi to grow, then if there's any growth in the intestines baseline, you may worry that those polyps, or even if they're malignant type of growth, may grow as well. So as far as that, any patient that was over 12 years of age was scoped prior to entry into the study to clear them from any growth or polyps before entering. And then there were some time points during the study that stool guaiacs were obtained, and if they were positive, that triggered investigation by colonoscopy.
Okay, I think we'll move along to the next topic. Thanks very much, Beth, and it's good to finally meet you. Okay, go ahead.
Was the target of this safety or benefit or both for children?
This initial trial was designed to demonstrate safety of the medication, and a secondary goal was trends in efficacy, but the main design was safety.
Okay, we're going to have to go to the next speaker, but, and that will be Joan.
No.
Okay, the second winner, you get it? Thanks, is Vicki Ross, and Vicki works with FASPEN in Silver Spring, Maryland. So Vicki, come on up.
Come and get it.
Congratulations. Yes. Good to see you too.
Wear your ribbon?
Yep. And here's your. So now, if you can find a place to put all of that stuff, like maybe down here, I'll introduce your topic. This is another multicenter trial, right?
This is a data registry?
Oh, from the data registry from Sustain. So that makes it multicenter. It's central venous catheter infections in home parenteral nutrition patients, outcomes from the Sustain program at ASPEN, the ASPEN's National Patient Registry for Nutrition Care, and the multiple authors include Dr. Vicki Ross, Dr. Peggy Gunther, Ms. Mandy Corrigan, Ms. Deborah Kovacevic, Dr. Marion Winkler, Dr. Helene Resnick, Dr. Tina Norris, and Dr. Lawrence Robinson, and Dr. Ezra Steiger. So we'll turn it over to Dr. Ross, and I'll get all my stuff off of here. That'll give you a little more room.
Clicker is,
The clicker is that one,
okay.
and this must be advanced. Let's see if that works. It doesn't work. Nobody told me. This works. Let's see. So let's see if we go back. Where's the projector? I think it may have to be
Where's, oh, down here. Huh?
here. The fellow's coming up who can straighten us out.
I need instruction 101.
Well, and I haven't.
So
used
just
that
so
one
I-
before, so. Does it, where does it
Okay.
have to point? Oh,
Okay, so I was pushing it, and the red one is a reverse. Well, again, my name is Vicki Ross, and it is an honor to present our data to what I believe is the most important part of both Oley and ASPEN, and that's the consumer. This article was published in the American Journal of Infection Control, and I'm particularly proud of that because that is a journal that's read by more than what I call the choir or ASPEN, but really practitioners in the field who we wanted to get the word out about the importance of HPN and the risks involved. You'll probably have heard many of your providers talk about evidence-based practice. We believe that's the best outcomes when we take into consideration those three components: the consumer preference, the resources available, and the evidence. When you think about consumer preference, it's a PICC line versus a tunneled catheter, a Hickman. The resources, if the consumer is looking at or the patient is looking for a PICC line, but there isn't the staff that can put it in, or the expertise, or the surgery schedule isn't open to put in a tunneled, those have to do with the resource components. And what I would like to talk about today is that most important piece, which is the evidence. They're all important, but that evidence, what we were seeing more and more is HPN has been around, home parenteral nutrition has been around for a long time, but there is not a large data set. And large data sets, particularly what we call registries, are helpful in trying to understand phenomenon that are going on and to describe that picture. So ASPEN was acutely aware of that need for some current data in the US about HPN, and so went to great lengths to develop and create the Sustained Data Registry. This is a voluntary registry. There are some registries, data registries, that are mandatory if you're starting a new drug, or some of the Medicare stuff you have that are very specific, that if a patient is getting dialysis, there's, they have to have data and put it in. The HPN data is not like that. There's nothing in your provider requirements that says that they have to enter the data someplace, and that creates a lot of problems. So the ASPEN registry, the Sustained Data Registry, was a voluntary registry in that providers could choose to participate and submit their data or not to the registry. It was prospective and observational. Many of the studies that are out there about HPN are chart-related, so a practitioner may go back into a chart and do what's called a retrospective review. We really wanted to set up the questions early on in the Sustained Data Registry and collect data that would help answer those questions about HPN therapy. And the data includes all of the voluntary sites that entered both adult and pediatric data. So what you'll see today is both adult and pediatric data combined. The purpose of this study was to describe the central line associated bloodstream infections, or CLABSIs for home parenteral nutrition, for the patients that were followed from 2011 to 2014 in the Sustained Data Registry. So in order to be included in this study, we needed both what we called the baseline data, when patients were initially enrolled into the Sustained Data Registry, and then when they had another provider encounter. whether they came in for a checkup, whether they came in with a problem, that follow-up visit. So we needed to have both of those so that we could look longitudinally at what was happening with the HPN and particularly the catheter-related infections. I think it's important to note that 21 of the 29 sites who volunteered to collect data and submit data to the Sustained Data Registry were hospital-based outpatient providers. And the rest were like home care providers that, or smaller entities that didn't have maybe one or the other. But many of them were hospital-based. And that it's also important to note that we went back and asked the sites how they were determining which data were entered into the Sustained Registry. Because as a researcher, you're always concerned that perhaps your data are being cherry-picked and only the best data go into the registry. And when we went back and asked the sites, 83% of those were consecutively enrolling. So it was all comers as they were coming in. So the majority of them were not being cherry-picked or selected. There were some sites that chose only to enter brand new HPN patients that were just starting and hadn't been on it for a long time. And so that constituted a fair percentage of that other, 17%. So there were 1,046 patients in the registry for which we had data. And of those, 10.7%, or almost 11%, experienced at least one infection, one central line associated related infection during the time they were followed in the sustained data. When we look at that, the risk of having an infection is different for somebody who has a catheter and parenteral nutrition for one day versus someone who's been receiving it for over a year or more. So in order to standardize that, we look at a rate, and the rate is determined by the number of infections over the number of PN days. And these were PN days for which we were following them in the Sustained Data Registry, and then times 1,000. And so what you want as both a consumer and as a practitioner is for that rate to be zero or as close to zero as you can get. So that was the overall rate for this group that we had. Then we wanted to try to dig down a little deeper and see if we could see differences between groups. And right off the bat, the thing that was staring us in the face was this difference between adults and kids. And those are defined as adults who are 18 and older or younger than 18. And the difference in that infection rate for those, and I'll talk a little bit more about the limitations of this study later on, but know that for the sustained data, what we found was that kids had a higher rate of infection than for adults. That the payer source, sites were asked how, what the payer source was for the therapies. And Medicaid, those that were receiving Medicaid had a higher rates of infection than both private insurance and even Medicare. We think sometimes that elderly persons have higher risk of being sick or not well, but if you look at this, the rates of infections for those that were 65 and older, which is where most of the Medicare patients were in, was about the same as the private. It was the Medicaid. Males were higher, and while those rates were lower, there still was a difference between males and females, and again, minorities versus whites in terms of those infection rates. From a research standpoint, we look at the statistics and we talk about chance. If we flip a coin, we have a 50% chance that it's going to be heads. And so what we want to know is, what are the odds that this could happen just by chance? And we set what we call the p-value to be 0.05 or less. So when you see the asterisks beside those, the children, the Medicaid, those differences were what we call statistically significant, that there's a very low chance that those were happening just by chance alone. We also, in addition to the demographics, wanted to look at the catheter characteristics. Surprisingly, the PICC lines actually had a little lower infection rate than the tunneled. Most of the patients that were registered in the SUSTAIN database, over 90%, were either PICCs or tunneled catheters. There was a smaller percentage that were ports, and the ports had the higher rate of infection there in this study. When we look at duration, so the duration of the HPN, whether they were on it for less than 90 days or greater than a year, it seemed that the longer patients were on HPN, the lower the rate. And that might make sense as people kind of learn to kind of what works for them and the sterile technique that's required to deal with these lines over time. So the rates were significantly different between those categories. Single and double lumens, if some patients require a single lumen, others require a double lumen, maybe for therapies. It's thought that the more manipulation is required when you have 2 lumens, you've got to take care of 2 kind of ends there, that rate goes up, and it did in this study. There were very few triple lumen catheters, but there were no infections reported in those few triple lumen catheters. So we do see some statistical significance in those as well. Ethanol locks are used for as a means to prevent infections for these CLABSIs. And surprisingly, so you see a difference, a statistically significant difference between the ethanol locks, between those who reported having an ethanol lock and those who did not. And yet it's in the opposite direction. So you would expect kind of the ethanol lock to have a lower, whether those individual patients were already had other underlying conditions, most likely that contributed to this difference in an opposite direction. That's kind of a limitation with the data registry. We don't get to go back and ask or randomize from these. But it is important to note the use of anti-infectives. So sites were asked if the patients were on antibiotic therapy. And so it was a yes or a no. And there really was no difference about in the rates for infections based on whether they were on antibiotics or not. As a researcher, anytime, there's no perfect research study, sadly, but we look at the limitations and how much we can generalize these data to a population or use these data. So when we talk about registry data, it's observational. We didn't have any control over who was in which group, so we could randomize the groups and maybe equalize the potential differences that we don't really know. So it's observational data that we have here. And we had to combine data for potentially dissimilar groups. I can't tell you how much I went round and round with our statistician about really wanting to separate the kiddos out and dig deeper into that group. But because as a researcher, we set up our questions before we start, and we don't get to go back. And there are all these issues related to numbers and statistical power and how many times we can ask these questions. We left it at this. But we also believe strongly that that's an area that really needs to be looked at, is why are we seeing these differences in kiddos? Is it an underlying condition? Is it, the type of catheter? We can't really say from this study. We only know that there is a real question that needs to be addressed here. And the voluntary data set that I've talked about before. So there's no mandatory reporting. It's potential. There's probably a lot of single providers who could not, it took a fair amount of time to go through the training, to enter the data, to look at all these things. And so the providers who volunteered to do this really should be commended, because it couldn't have been done without their willingness to see this as a very important question. In conclusion, we can make some conclusions from the data, and that is that CLABSIs are and continue to be a real concern for HPN. 1 in almost 11 people experienced 1 or more infections with these lines. And the data would suggest that there are some real differences between demographics, clinical, and catheter characteristics that need further research so that we can understand the best way to address those and reduce that CLABSI rate as close or as to 0 as we can get. And that really requires prospective randomized clinical trials in many of these cases to begin to compare head-to-head comparisons. It's kind of small in print, but just to share with you all of the individual providers that willingly shared their, and these data were de-identified, so there was no way at FASPEN or SUSTAIN that we could go back and say, oh, that was Mary Jones's data. It was all de-identified data that these sites were providing to us and willing to share kind of all of their laundry. Questions?
Thank you, Vicki. Let me just ask one question first. It's the introducer's prerogative. One of the interesting things that would have been nice if you could have determined what the teaching was is that ports, the ones that are totally under the skin, a lot of us teach people that if they're going to use a port, they have to access it every single day and de-access it so that it's not providing a route in for the bacteria while you're not infusing. And it would be really nice to be able to determine whether there's a difference in that practice. And of course, you don't have any idea what people are being taught in this kind of questionnaire. So, and the other one thing was I was going to say with the ethanol locks, it's possible that, as in our practice, if somebody had not had infections, we didn't usually use ethanol locks because they were already doing it well. So how could we improve on perfect practice? So you may have had the high-risk people in some of the practices who use the ethanol locks, and they may already have a tendency to have more infections. So, okay, you have a question.
The question was about various different catheters. Did you check out Broviac, Hickman, or other kinds of catheters as to success rate or infection rate?
In the sustained data registry, when providers enter data, they will describe the catheter, but in order to put them all together, so that when you start breaking out catheters to very specific brands, we lose what we call power, or the ability to begin to extrapolate the data. So they were categorized as a tunneled catheter, which kind of works similar to, which is different than a PIC, which is different than a port.
I just know that there have been some people that say Broviacs last a long time, and maybe Hickman's. I don't know. Everyone has different things, but I wondered what your research had said if you had actually broken it down to the different kinds of catheters as to which worked better, or which had less infection rates.
Right. We didn't ask that question for these data, and I'm not sure, given the sustained data. So, cost a lot of money, a lot of time. These were all volunteers, so the sustained data registry is no longer continually collecting the data. So you only have this frame of 3 years, and I'm not sure if even your question about length of time, how long does a Broviac last longer than another catheter? I don't know if we could even ask that question.
And one thing that might happen if they had selected out Broviacs is they probably would have a preponderance of Broviacs in the children's group and not in the adults, because the Broviacs are much smaller catheters. So that could have screwed things up further, so. Okay, we have one back here.
Yeah, I had a question. For patients that already had an infection once, did you do any studies about repeat infections for those patients?
So the question was, did we do more in-depth analyses for infections to see if it was a repeat infection? When patients came into the study, their baseline data, they could have been on HPN prior to entering into the study, but day one was considered the day they entered the study, because all of the data prior to that was retrospective, and the SUSTAIN is about prospective data. When providers reported an infection, there were questions that were asked about the kind of organism, if they had previous infections, and there were some, as you can tell from the group, that had more than one infection for that rate, but there was like 11% that had one or more. So most of them had one.
Let's get the microphone up.
Sorry.
Oh, here, we have one more back there.
Hi. I have two questions. I was wondering whether education level had anything to do with the probability of infections. That was one. And the second one is, I'm a math teacher, so please excuse this question. I was confused that you had probability. I wasn't sure whether those were probabilities or percentages. So when you said 0.35, is that really 35%, or are you talking about less than 1%?
The rates are what's being reported. The asterisks after those tell you the probability that those rates would occur by chance. So you're actually seeing the rate, which is a measurement of the number of infections divided by the total number of PN days, parenteral nutrition days, times 1,000. So we could standardize the exposure to the risk, which is the catheter and parenteral nutrition, so that someone who's only on parenteral nutrition one day is standardized to the one who's exposed 365 days. So
Okay, so it was hard to compare those probabilities to the percentages that were
Yeah,
up
there's
there.
no probability. The only probability is what is the probability of getting that rate, those differences in rates, by chance.
Okay.
And that's a statistical test that is done. That's what we call the p-value, or the probability that those two rates would occur by chance alone, the difference in those two rates.
Okay, and we have one more question, and that'll be it. So
I have three, but I'll condense them. Was there any way for you to control how the catheter was cared for in the home? Was it an infusion company, a VNA, who was doing the dressing, what products they used? That's my first question. The other thing is, for the CLABSI infection, how did you define it? Was it by culture tip, by blood cultures? Because so often somebody spikes the temperature, they come in and everybody's like, get every tube out of them. And then you find out, of course, the PIC was never infected. So is there a way, and then there's some facilities that do culture tip that come out positive or negative, but that's kind of gone by the wayside. So how did you determine what was really a CLABSI?
Okay, let me go ahead and answer those two. So the first one had to do with...
How did you standardize what care was delivered in the home?
So the care, these
catheter.
are providers that are entering the data, and so it was very easy for us to get who was the payer source, the kind of catheter they had. We lost a lot of data when we started asking questions about who's caring for the catheter
who's doing the dressing
home.
change?
Yeah, and so we really couldn't address a lot of those questions that we'd really like. How much, what teaching they had, those kinds of things. And then the definition for infection. So when you look in the literature about HPN, there are a lot of small studies, and they define, you're absolutely right, that infection differently. And that makes it difficult to compare because now we're comparing apples and oranges. In the SUSTAIN data registry, there was a very specific definition for CLABSI, which was the central line bloodstream infection. So it did not require that the catheter had to be removed to be cultured.
Good.
Yeah, so we use those standards.
Okay, thank you. And you're giving a breakout session?
Yes.
Yes, this
I
is
will
a
be
free
there.
advertisement. Go ahead.
I'll be there and happy to answer any other questions.
Okay. Joan? Well, but you got to get this stuff up from down here. And is that Vicki's? That's yours, Vicki?
Yep.
Vicki, you must take this home. And this. This is yours too. So if
There we go.
you want to come on up, Dr. Vout. Now, I have to apologize to our next speaker because I don't speak Dutch. I don't speak any of the languages of the countries that are, except English, presumably, that are included in this study. So I'm probably going to slaughter some of these names. But this is Dr. Yannick, do you say Wouters? Starts with a W and it sounds like a B. So anyway, for us, who is the next winner, and he is from Nijmegen. I knew that one. That J is a Y. The Netherlands. And I'm going to list all of the people who worked with him, and this is where the slaughter begins. So he is the first author of this paper. All right, Miriam Thila from Israel. Yes. Professor Pierre Singer from Israel. Where's Siri from?
Siri Tribla. She's from Denmark.
Okay. Siri Trisla. That's not right, I don't think. But anyway, from Denmark. This one I know because he's a friend of mine. Pele Jeppesen from Denmark. Loris Peroni, also a friend of mine from Italy. Lars Winter Janssen. Also Denmark. Okay. Henrik Rasmussen, also Denmark. Farouk Rahman is from the UK, I believe. And then Geert Wanten, who is a friend of mine as well, from the Netherlands, were the co-authors. Excuse me. And the title, Taurolidine locking prevents catheter-related bloodstream infections in patients on home parenteral nutrition, a double-blind, randomized controlled trial. So I might ask you just to tell them what double-blind, randomized, and controlled means. Yeah. So anyway, Dr. Wouters.
All right. Thank you very much for that I'm being here. I'm very grateful to receive the award, and also on behalf of my supervisor, Geert Wanten. I'm glad that winning this award gives me the opportunity to present my study here for the patients that the research was meant for. And hopefully my research will give you also some new information and some new insights about catheter lock solutions. All right. Well, my name is Yannick Wouters, and I am a doctor and also researcher from the Radboud University Medical Center in Nijmegen, in the Netherlands. And we have performed the last couple of years a randomized controlled trial in several countries. We did that where we compared catheter lock solutions, the catheter lock solutions Taurolidine and saline in patients on home parenteral nutrition to prevent catheter sepsis in these patients. Well, first of all, the study was sponsored by Geislich. This is the manufacturer of Taurolidine, and they call their medicine Taurocept. First, I want to introduce the catheter sepsis part a little bit more by a case that we had in our hospital. It's about Mrs. B. She is 35 years old. a woman and a mother of 3 children, and she had until recently no medical history of any kind. But 3 months ago, she was hospitalized because she had severe abdominal pain, and it turned out she had a mesenterial thrombosis, which means that her blood vessels to the bowels were occluded. And for this, she needed extensive surgery. She got a lot of resections of her bowels, and eventually she remained with a short bowel syndrome and high output stoma. Because she couldn't eat because of the high output stoma, she received a central venous catheter, and she started training for home parenteral nutrition. So after 3 months, she was discharged home. Hopefully that was the end of her period of sickness, and she was trying to rebuild her self-confidence in her own body, and also in the aseptic techniques that she had to learn now because of the home parenteral nutrition. But unfortunately, after 2 weeks at home, she became ill. She got malaise, fever and chills, and she was again hospitalized. She was admitted to the hospital, and it turned out she had a catheter sepsis based on a Staphylococcus aureus infection, which is a bad monster. And well, she needed to receive a lot of weeks antibiotics, and also her catheter was removed. Well, I think those cases are not one of its kind. I think a lot of patients has experienced in the past bloodstream infection. I'm not sure, are there any people here in the room that have suffered from a catheter sepsis? Yeah, I see some hands, yeah. Well, that's also what we see in our centers in Europe. Every patient experiences about 1 sepsis every 1 to 5 years. And of course, there are several measures to decrease these catheter sepsis. And I think on this list, the training to perform aseptic techniques is the most important one. But there are also other measures, such as antimicrobial filters, topical antimicrobial agents, and also systemic antibiotics. But no measure sufficiently is effective to prevent all these catheter sepsis. So there are still catheter sepsis left in patients. So what else do we have? Well, the use of catheter lock solutions has been advocated to prevent catheter sepsis in patients on home parenteral nutrition. What is a catheter lock solution? Well, you can see it here in the animation below. We have a syringe with the lock solution inside of it, and we connect it with a catheter. And after that, we instill the lock solution into the catheter. And now it should have some preventive effect on bacteria that try, of course, to invade the catheter. But, yeah, well, it doesn't work in this situation. Well, there are many types of lock solutions. You see them here. There are antibiotics, such as vancomycin, anticoagulants, such as heparin, and also antiseptic agents, such as ethanol, like was told before in the last presentation. But, however, most of these lock solutions have been abandoned because of side effects or damage to the catheter, such as in the case of ethanol. Ethanol isn't recommended anymore by the ASPEN guidelines, the European guidelines. The development of microbial resistance, we can see that in antibiotics, of course, or there's just lack of effect, as we can see in heparin or also ethanol. So the question remains, what else is left? Well, in Europe we have two lock solutions left. We use Taurolidine or we use saline. Saline is also used, I think, here in America. The advantages of Taurolidine is that it is a potent antiseptic agent. It has an activity against both bacteria and also yeast because it reacts with the cell wall of the bacteria and destroys it. It is also a non-toxic agent because the Taurolidine degrades into non-harmful products like carbon dioxide, water, or taurine, that is an amino acid that you have in your body. There are to date no reported side effects. There's no bacterial resistance because it's an antiseptic agent, not an antibiotic agent. And it works in the HPN setting. We have proven that several years ago when we compared Taurolidine with heparin. Saline is also non-toxic. There are no side effects, and it is very cheap. But the question is, does it work? It has never been proven that saline prevents infections in patients. So that's why we compared now Taurolidine versus saline. We did this in a multicenter study, and well, the centers that participated were in Denmark. There were 2 in Denmark. There was one, you can see it over there, in Israel, one in Italy, in the Netherlands, and also in the United Kingdom. And the patients that could be included in the study were male or female, between 18 or 80 years, and they had to have a benign underlying disease leading to intestinal failure. And they needed as well at least 2 bags of nutrition or fluids per week. They were subsequently randomized, which means that the patients were divided over groups, over Taurolidine and saline, just by coincidence, so to Taurolidine or saline. And they were also blinded, just like the investigators. This means that the patients and also the investigators didn't know what medication the patients received. At the end, in Taurolidine, 52 patients were included, and in saline, 50 patients were included. And the patients were followed for 1 year, in which the patients had to use the catheter solution during the time they didn't use the catheter for infusion of home parenteral nutrition or fluids. The most important outcome of this study is the catheter sepsis between Taurolidine and saline. That's what it is about. But there are, of course, other outcomes, and I've picked 2 important ones: the removal of catheters, and also the safety, of course, of both the products of Taurolidine and saline. Well, the baseline characteristics of the patients were similar. I have summarized them here in some slides. And what we saw were that 40 males were included in the trial and 62 females in the trial. The average age of all patients was about 52 years. The cause of intestinal failure was in 60 patients a short bowel syndrome, and in 29 patients this motility disorder. And the other causes were, for example, intestinal fistulae or extensive mucosal diseases. The catheters that were used were in 57 patients a Hickman catheter, and in 24 patients a Broviac, but were also patients with a PICC line or a subcutaneous port. What was interestingly to see is that 50% of all the patients had a catheter sepsis in the past. Well, I think this is the most important slide of all my presentation. So if you walk out of this room later, just remember this one. This is the most important. What you can see is it's about catheter sepsis between the group of Taurolidine patients and the group of saline patients. And well, this is about real time as that it gets. You have here 1 year of the study, and you will see when I start the animation what happened with the patients, who got an infection and who didn't. If they got an catheter sepsis, then they turn red. So just watch, especially the first 5 to 6 months, because then it happens the most. As you can see, most of the bloodstream infections are in the saline group. And well, if you wait until 14 months, eventually 5 bloodstream infections or 5 catheter sepsis occur in the Taurolidine group, while in the saline group 18 infections occurred. So there's a difference of 13 bloodstream infections, and that's a significant difference. If you recalculate this in risk rates, then you can say that Taurolidine reduced the risk for catheter sepsis by more than 4 times when compared to saline. We did this also, this animation for the removal of catheters because of the catheter sepsis. And you can see that now. And of course the consequence was that more catheter sepsis occurred in the saline group, so also more catheter removals occurred in the saline group. And this was also significant different. Then the side effects, well, there weren't any really bad side effects. There were some mild side effects such as flushings or headaches, but it was very rare and it occurred in both groups. But real serious side effects didn't occur, so it's quite safe. So if you see the strengths of our study, then we can say it was a large study. It was a large group of patients, and it was a high quality design because we blinded the patients and also the investigators, and we randomized patients. The population that was included in the study was a good representation of a chronic HPN population, and it was also a pragmatic design that we used. Because the daily practice remained unchanged as much as possible. For example, patients instilled the catheter lock solution themselves. Nobody else did that. There are also, of course, some limitations to this study because there were several centers included in this study, and several centers may have several different hygiene protocols, so different rates in infections, so that could have influence the outcomes. But what you should remember is that Taurolidine reduced the catheter sepsis by more than 4 times when compared to saline. There were less removals of catheters in the Taurolidine group, and it was safe to use. So therefore, based on these factors, we recommend the use of Taurolidine in all HPN patients. That's it.
Thank you, Yannick. Well, first of all, you need to know that this drug is not FDA approved, cannot be used in this country. So I think we should have Yannick come back and speak to the FDA, frankly. But I've heard about this drug for a long time because of working with Gura on the home artificial nutrition work group with FASPEN. And it sounds tremendously possible that if we could get it here in the U.S., I think it would be a good thing for you. Yeah. But the FDA sometimes takes a while. So at any rate, we have a few questions, if we can get our microphones up there. I'm not sure that the different centers is a limitation. I think there's both some advantage and perhaps some disadvantage to having different centers because you all are managed by different centers, and so it's more practical for what the practice is.
Yeah.
So, I guess I wouldn't too strongly be concerned,
no,
but...
I think because you have more centers, you have a better representation of HPN population.
Exactly.
But you don't know exactly what the infection rates are. But
Yes.
the difference between the infection rates stays the same. That's always there is always a difference between Taurolidine and saline.
Right. Okay, yes. No, it needs to be turned on.
We don't use heparin. That's obsolete. No.
How would you get this if it's not FDA approved? Could you still get it at this point at all?
No.
No. So we have to get it approved.
It has to get
You can
FDA
smuggle it
approved.
in through Mexico.
Unfortunately. Okay, next question? Jack has one over there.
Maybe I misunderstood something, but your earlier slide talked about how heparin and ethanol were not effective, and so I've been on heparin now for the last 3 or 4 years. The first 5 years I was on a line. I had just a PICC line. I had 5 infections in 5 years, 2 of them life-threatening. But after that, for the last 3 years, I infuse every day. I flush 2 saline and 1 ethanol every day, and I've been infection-free. So I'm wondering how this product compares to ethanol. I'm sorry, to heparin.
To heparin. Taurolidine versus heparin. That's your question?
How does it I use heparin to block infections, and it's been very effective. So
I think the most important part is that a catheter solution is used additionally next to the aseptic techniques. So I think the most important thing is always the aseptic techniques that you use to connect your catheter to a pump. So if you are going to be better in the aseptic techniques, then you sometimes don't even really need a catheter solution because you do it very good. You don't get infections because you use the aseptic techniques right. But if you compare the Taurolidine with heparin, we have done that. We have made the comparison in a trial like 9 years ago. There we saw that also Taurolidine works far better, like 90% better than heparin. So we don't use heparin anymore, and also that is not recommended anymore in the guidelines.
And heparin is really a drug that is supposed to prevent clot. And so that's assuming that clot is associated with the infection. So,
But what we also see is that when you get infections, you probably also get occlusions because of the infections. So you better prevent the infections, and you also prevent occlusions.
Hi. Dr. Harvey, fascinating study question. Did you differentiate between infections caused by primary seeding of the line from the skin and the hub versus remote seeding from a secondary source, and did it make a difference then?
Well, we have looked at exit site infections, if that's your question, but there was no difference between the groups.
Sorry. There's 2 basic sources for the infections. Most of them come from the skin, they come from the hub, versus you have secondary seeding on patients who, say, have Crohn's disease, something like that, get an infection, seed the line, dental abscess, seed the line, and such. Did you differentiate between infections caused by primary versus secondary seeding?
No, we didn't. That's, I think, difficult to check how it was. How did you get the bacteria from your skin or from somewhere else?
Not really. It's different bacteria. When you start to see gram-negatives and things like that, you start looking for secondary seeding. Mm-hmm. When you see staph and strep, then you're looking for primary hub seeding. So I'm saying, when you looked at the infections, did you look at the bacteria?
We looked at the bacteria, but we didn't check its source, where it came from.
I think so. And we have that issue of choice of drug here, because yours is not one of ours. So a lot of people are on alcohol. There have been some with complications related to the alcohol. We've had some that draw clot out of their catheters very frequently, but of course they're also drawing back the product. And in Europe, you don't draw blood from the catheter for routine tests, just if you have to identify a bacterial or fungal source. Yeah. And there's a big feeling that drawing blood into the catheter puts you at much higher risk for infection. Okay. Oh, okay.
Well, I find that in teaching the flushing protocol, we used heparin to reduce fibrin accumulation. Blood tends to stick to plastic. And so heparin was basically prevent fibrin formation because that sets up the environment for catheter, a bloodstream infection. But then we switched to saline, and we found it's more effective with an aggressive pulsatile flushing to eliminate blood sticking, how I say to the patient, blood sticking to plastic. And so I'm wondering the introduction of it. The other thing is that the catheters in the last few years have gotten so small. Your double lumens now are the size of, what a thin single lumen was years ago. And that in itself, even with pulsatile flushing, does cause more complication because people are pulling back aggressively like with a blood draw, and it differs from agency to agency. But I'm just curious. Sometimes I find people do get confused about why do we talk antimicrobial installation as this is an option in your country, versus just pulsatile flushing with saline.
Yeah, well, I think you're correct that the flushing might resolve some of these issues of biofilm formation. I'm not sure if heparin really works anti-biofilm formations. So the flushing might reduce the risk for biofilm formation. I know that Taurolidine also prevents biofilm formation, so that's another additional advantage of using Taurolidine. So you don't have to extra flush it or something, you just instill it and it also prevents the biofilm formation. Yeah.
There was someone just right around.
Does it Does it cause the catheter to wear out sooner?
No, the catheters stay longer in. Yeah, that's not based on this trial, by the way, but we see that in also other studies.
One more question.
It costs more than saline, but because you have more infections in the saline group, you pay a lot more for the research use of treating these infections. Thus, the costs are the same in both groups when you take the bloodstream infections with it.
Okay, I think we need to go ahead to the next step. One quick one.
Okay, in the 102 patients that you studied, and you found that there were 5 incidents of catheter infection in the Taurolidine versus 18. When you did your calculations, what were the actual CRBSI rates per 1,000 catheter days?
It was 0.3 in the Taurolidine and 1.44 in the saline group.
Okay. All right. Well, thank you very much, Yannick. And like I say, if we get this up to FDA, you got to come back.
I will. Thank you.
Okay, just quickly, thank you to NutriShare for supporting the prizes. Thank you to the recipients for joining us and sharing their research. It's worth mentioning that the prize is $2,500. However, they are to spend $1,000 of that to get to the Oley meeting. So we end up with great presentations. So thank you all to agreeing for that, to that special request from us. And thanks to Andrea and Dr. Kelly for coordinating this session. Now, moving along quickly, our next presentation, Oils Well That Ends Well, Lipids that is, with Kathleen Gura, who will tell you a little bit about herself before we begin, but we really appreciate her continued support of Oley. I'm a helper.
That'll hold you up. Well, good morning. Thank you for having me. It's always fun to be here. I learn a lot from you, the consumers, as much as I hope I can share what we do. This year I was asked to speak about lipid emulsions. only because now we have choice in the marketplace, something we haven't had for decades. I'm a bot woman. I do get research support from various organizations, so there are my disclosures. We're going to talk briefly about how these products came to the market. We're going to talk about what the data was, that wasn't me, what was used to approve the products, just so you could appreciate what I tell you, why we don't have Taurolidine in the US when I tell you why lipid emulsions were a problem, bringing those in, and what the differences are in all the new products that we now have in the marketplace. Just for a little trivia, lipid emulsions are not new. We've been trying to get this right now for centuries. In the 17th century, there was this physician, Dr. Korson, who gave straight olive oil to dogs. Dogs didn't do well. They all got embolism, they died, because it was straight olive oil. And then during a cholera epidemic in Canada, this other, Edward Hodder, gave milk IV to people. Miraculously, they survived. That was before we had germ theory, so who knows what was going on. Nobody else could reproduce the results. And then after World War I, that's when we started to see some improved technologies. War is actually very good for IV therapy. A lot of the improvements we saw were the result of war. IV catheters came out of World War I. So sometimes war could be good. But Japan and the US were in the great race to develop lipid emulsions. From 1920 to 1960. And in fact, if you look at the data back then, they didn't call it lipid emulsions, they called it artificial chylomicrons. So if you look in the old references, that's the search term people would look up. You wouldn't look for fat emulsion or anything like that. And because we learned that dogs died when you gave IV oil without any emulsification, they had to come up with a safe emulsifying agent. In order to get that oil into the water so they could give it intravenously. If you're a chef or you know how to make mayonnaise, that's what you're doing. An IV lipid emulsion is like making mayonnaise. It's an oil and water emulsion, and it's not as easy as you think to make it. It's kind of an art. That's why there's not much out there. And in fact, we've got a product in the 1950s, early 60s called Lipomol that the U.S. had. It was made by Upjohn, and it was made with cottonseed oil. And it was emulsified with soy phospholipid and polaxamer. That's actually what makes ice cream smooth. Unfortunately, they didn't get it right. A lot of side effects, and as a result, patients got sick, they died, and it was pulled off the market by the FDA. So the FDA didn't like lipid emulsions. In fact, they had no interest in bringing a product to market. So that left only dextrose as our calorie source for IV therapy. So over in Sweden, Dr. Arvid Retland is actually the man that brought the field forward. He's considered the father of complete nutrition. He's the gentleman you see with Dr. Dudrick. In 1961, he came up with the egg yolk phospholipid emulsifier that we use in all lipid products today. So he made it a safe emulsion. So what's common to all these products? Well, all these products have water for injection in it. As I mentioned before, it's an oil and water emulsion. So the majority of these products are simply sterile water. There's the egg yolk phospholipid emulsifying agent that keeps the oil in the water phase. That's what Dr. Retland developed. There's no egg-free lipid emulsion anywhere in the world. They also have glycerin in there to make it isotonic, to keep it stable. It's a stabilizer. And it also has sodium hydroxide to keep the pH high. Fat emulsions typically have a pH of around 9. By the time they're expired, they go down to 6. Now, for anybody who has a child who gets a TPN, they have a lot of calcium phos in those solutions. They need a pH that's low, so it's kind of which is more important. With the lipids versus calcium phos, it makes it a challenge because dextrose protein tends to be acidic. So it's like putting lemon juice and tea with milk. It might curdle if you don't do it right. So what's different? What makes these products different? Well, we'll talk about these differences, but it's the phytosterol content, how much vitamin E is present in the emulsion, as well as what's the inflammatory characteristic of that oil source itself. And none of this stuff is on the product label. So you have to be a geek and want to go into the references to look at it, or find somebody like me who's a geek who read the references. Phytosterols are actually plant sterols. They look like cholesterol. And when you take it by mouth, very little gets absorbed. However, when we grind up like a soybean to make it an intralipid and to give it a lipid emulsion, you give it IV, you bypass your stomach and your GI tract. And when that happens, you get all that phytosterol in your bloodstream. And that's been shown to decrease bile flow. So you can get stasis, might contribute to liver dysfunction. And when you look at the different products, so let's see if I got the pointer here. Yeah. The different products, you do see a difference in the amount of phytosterols. Intralipid, being pure soybean oil, has the most phytosterols because it's all plant. Now to compare that to fish oil or omegaven, there's very little phytosterols, and that's because the only phytosterols you see in omegaven is what the fish ate. Fish, without it, don't. The next one, vitamin E, is in the form of alpha tocopherol, and that's added to oils as an antioxidant. It's been shown to prevent hepatic injury. In fact, before the Europeans had choice in their lipid emulsions, there was a physician, Olivier Goulet, who routinely added vitamin E to his intralipid to prevent liver disease. But now he has different options available. But it's been shown that if you take prolonged infusion for courses of therapy of pure soybean oil, you may deplete your natural cell membranes of alpha tocopherol. And in fact, if you look at soybean oil, it's in the form of what's present in soybean oil is gamma tocopherol, which is less bioactive than alpha tocopherol. And when you look at the different lipid emulsions, you also see that they're different in vitamin E content. Intralipid, as I already mentioned, has very little vitamin E. Omegaven and SMOF, because they both have fish oil, both have more vitamin E because when the refinery that makes the oil for those products, they have to put it in at the time of processing. Why is this jumping? I didn't touch it. I don't know how to go back. I'm sorry. Okay. It goes back. Let's see. They have more vitamin E just because they have to at the time it's processed because it will get rancid. So you can't have a fish oil emulsion without vitamin E because they have to make it at the fish refinery when they process the oil so it doesn't go bad. So let's talk about the specific oil sources. Soybean oil is the first one that did come to market in Sweden in the 1960s. It's a blend of omega-6, which are pro-inflammatory fatty acids that are actually metabolized to arachidonic acid, has a little bit of oleic acid, which is omega-9, has a little bit of omega-3 fatty acids. Very low naturally in vitamin E, and has a lot of phytosterols because it's all plant. The dosing is fairly been well described. You only need 8 to 10% of your total calories as soybean oil to prevent essential fatty acid deficiency. So that makes it okay to do the lipid restriction approach where they do the gram per kilo per day to prevent liver dysfunction because it has sufficient essential fatty acids in the product. The other oil source, the M in SMOF, the MCT oil, is a medium chain triglyceride. It's either from coconut oil or it comes from palm seed oil. It has caprylic and capric acids, and it acts more like a sugar than a fat because it's readily oxidizable, so you can get some fast energy. It's considered neutral inflammatory characteristics. There's nothing there. It's just calories. So it may be protein sparing. It doesn't have any hepatotoxic properties, doesn't affect your immune function. So it sounds really good, doesn't it? And it's resistant to peroxidation. It actually makes more stable 3-in-1s because it doesn't impact the emulsifying agents. So it's actually a very good oil source for a total nutrient admixture where the lipids are mixed in with the dextrose and protein. The problem with this is it's no essential fatty acids. You will never see an MCT oil emulsion by itself. It has to be mixed with an oil source that has essential fatty acids like soybean oil or other oil sources. Olive oil has also been around since the 1990s. They've been using it in Europe and Asia since then. It's a blend of 5% linoleic acid. Soybean oil in comparison is 50% linoleic acid, the omega-6 fatty acid. So it's usually mixed with another oil source because it's fairly low in essential fatty acids. It's considered a neutral oil in regards to inflammatory characteristics. It naturally has less phytosterols in comparison to soybean oil, has naturally more vitamin E in its formulation. It's fairly stable. So, I mean, it's a fairly decent oil source, but it has to be combined with another. And the last, the F, is the fish oil. That's the opposite of soybean oil. It's mostly omega-3 fatty acids in the form of DHA and EPA. You probably have heard about that in baby formula. We use it for heart health. Has some arachidonic acid, which is an omega-6 fatty acid, so it does have all the essential fatty acids in its formulation. Because it's fish and not plant, there's very little phytosterols. The only phytosterols are what the fish ate. Very rich in vitamin E because it has to have vitamin E because of what happens at the refinery. And we know it for both nutritional benefits as well as therapeutic. In fact, we've FDA approved oral fish oil to treat hypertriglyceridemia. So there is some therapeutic benefit to it. So in summary, the function of all these different oils is on this slide. The soybean oil is simply a source of essential fatty acids. The MCT oil also allows you to decrease other oil sources and give calories. The olive oil has less anti-inflammatory, less pro-inflammatory properties. It also allows you to give less soybean oil. And the fish oil also has immunomodulating function. So again, they all have a little bit different, but they're all a source of calories. That's the thing you have to remember. They all have calories, and with the exception of MCT oil, they have some essential fatty acids. So why do we want to reduce the soybean oil in what we take when we give IV therapy? Well, again, we've learned over time that too much omega-6 fatty acids, too much of the pro-inflammatory fatty acids may not be good in many different patient populations, so we want to decrease it in our diet. And there's two ways you can go about it. One is to simply reduce the dose, or to mix it or dilute it down with another oil source that either has neutral inflammatory characteristics or different inflammatory characteristics. So that's why you're starting to see these mixed oil emulsions appear in the marketplace. The favorable balance between omega-6 and omega-3 fatty acids is theoretically 2.5 to 1 if you into the paleo diet. Intralipid, in comparison, has 7 parts of omega-6 fatty acids to 1. And if you look at a McDonald's diet, our lovely American diet, that's 16 to 1 omega-6 fatty acids to 1, very unhealthy. Back before the industrial age, we were down like to 2 to 1, so over time our diets have gotten progressively worse. And again, the emulsions are all enriched with alpha-tocopherol to maintain adequate antioxidant statics, so you don't get that peroxidation of the fats. So this is just summarizing all the different products that we currently have seen around in the U.S. And you can see that, soybean oil has mostly linoleic and alpha-linolenic omega-6 and omega-3, have to metabolize it down to these. The other two, omega-ven and SMOF, have less of those oil fatty acid products, but they have the downstream metabolites. So, I mean, they do have different ratios, so they are different that way. However, how do we get these products in the U.S.? This is something you might be intrigued at because everybody asks me always the question, why aren't certain products still not here? Well, Intralipid, again, was approved in Sweden in 1962, developed by Vitrum, which was a Swedish family company, eventually acquired by CABI. And in Europe, they've started to see a lot of generics come on the scene. However, because of the bad experience the U.S. had with Lipomol, didn't come over here. Dr. Dudrick actually had to do a lot of IV dextrose. They called his method the dextrose system. And when he had to provide essential fatty acids, he had to give the parents of the baby that was in that first case report a high-fat diet and give blood transfusions in order to give that baby essential fatty acids. That's how ingenious he was. He improvised, and that because he didn't have access to these products, so we gave them what they needed in the form of a blood transfusion. That's very clever. So the challenges in developing these products was simply, first off, to recognize the FDA viewed it as nutrition, as a source of calories and essential fatty acids. So you're not going to see an American study out there that's going to show you therapeutic benefits. It's very different than what happened in Europe and Asia. So the original products were all approved simply to provide calories, essential fatty acids, and make sure they're safe, because don't forget, we were comparing our experience to that lipomol disaster. No product to date has been approved in the US on a therapeutic benefit. Everything is strictly nutrition. And in fact, when you look at the safety profile, they looked at triglyceride clearance. They didn't look at other outcomes. They were looking at serum triglycerides to make sure the patients could clear their triglyceride levels. Intralipid, like I said, it was approved in Sweden in 1962. Didn't get approved in the US till 1975. And different concentrations were approved thereafter. When the FDA did approve the 20% application, they did ask for some data from the US. They took the CABI Vitrum data that they had in Sweden, but then they repeated some stuff with using the US Army. They looked at 47 patients. They only gave it from 6 to 21 days. How many of you have been on a fat emulsion for decades? This is how it got approved. 6 days to 21 days. And then they looked at the Swedish data. And that's how it got approved. In kids, they only looked at kids less than 4, nobody older than 4. And it got approved. Lipicin came on the scene. It was made by Abbott. A couple of years later, they had 3 different products. One was pure safflower oil, Lipicin Original. Then they had Lipicin 2, then Lipicin 3, which is all soybean oil. None of which you can buy anymore, but these are the 3 products. When Lipicin was approved, they actually looked at, again, essential fatty acid deficiency. They only used the trine to tetrine ratio. That's the ratio of omega-9 fatty acids to omega-6. No mention of omega-3 status. They looked at patients up to a month. Again, many of you have been on fat emulsions for decades, but they only looked at a month's worth of data. And in kids, they only looked at 5 patients who were on it for about a month. What happened, though, they noticed with Lipicin being the pure safflower oil, because it had so little omega-3 fatty acid, there were neurologic side effects that were discovered in case reports, and they did pull their product from the scene. And then later on, there was a safflower situation, so nobody wanted to sell them safflower to make the oil, to make the Lipicin 2. So again, eventually, there was no safflower oil lipid emulsions. Again, when Lipicin 2 went through their approval, they also looked at growth, calories, and they only studied it for 2 weeks. That's it. Not much more. And again, they did 43 children. That's it. And when Lipicin 2 and Lipicin 3 came on the scene, Lipicin 2 was that 50-50 blend of soybean safflower oil. They just looked at triglyceride levels, and it was approved based on the original Lipicin approval data. And Lipicin 3, which is 100% soybean oil, just like Intralipid, they didn't have any clinical studies done. They just approved based on the 10 and 20, based on previous data. And when the 30% was approved, they had 2 uncontrolled studies, so they didn't compare it to anything. They just looked at safety. And we had a drug shortage not too long ago, and there's a product by Braun called Nutralipid that was around in 1993, 10 and 20%, that they pulled off the market. I don't know why. I think it was probably for lack of sales. But because of the shortage, they were allowed to bring it back in. And it was approved simply being clinically non-inferior to Lipicin 3 and Intralipid. No claims. It's supposed to be considered equal. It's considered non-inferior. It wasn't worse, but it wasn't better. It was the same. And the way they figure a lot of this out is looking at the USP standards, and that's how you decide if the lipid emulsion's unstable. Is it a risk of causing an embolism if the particle sizes get too large and get trapped in your lungs? And the 2 things they have to look at are PFAT5 and mean particle sizes. And there's certain criteria. All the products in the U.S. currently meet that standard. But it's a challenge, and it's part of the reason why it's so hard to make them. I mean, I make them in the lab now, and it's a challenge to make sure you get the particle sizes just right. And if you don't do it wrong, you can't infuse it. So the new lipid emulsions in the U.S., what's different now in the approval process? Again, the FDA is still looking at the nutritional non-inferiority studies. They're looking for, make sure the patients still gain weight, they maintain their weight, that they don't get essential fatty acid deficient, they have normal triglyceride levels. So that hasn't changed. However, the FDA now is adding additional post-marketing studies if they deem them absolutely necessary. So now they're looking at phytosterol levels. They didn't care about phytosterol levels in the past. Now they do. They're looking at the PFAT5, that USP pharmacopeal specification, when the packaging sizes, design changes. For example, you're going from a glass bottle to a plastic bag. That makes the lipid emulsion pretty temperamental, and it's a challenge for the manufacturer to make sure it still complies, and sometimes it didn't, and they had to reformulate their products. And then pediatric specific studies. Right now, the new products are not approved for kids. So what has been approved since the 1990s? Well, there was a product approved in 2013 called Clinolipid. If you're from Canada or elsewhere, they call it Clinolaic. That was the first product to be approved in the U.S. Since the 90s. It's 80% olive oil, 20% soybean oil. Because olive oil has so little of the omega-6 fatty acid, you have to mix it. It was approved strictly as being non-inferior to intralipid. No therapeutic claims, no superiority. It was brought in to help with the lipid shortage because there was a shortage of fat emulsions around that time. So they brought it in that way. It actually has a black box warning on it in regards to premature infants. I only mention that because every single lipid emulsion that's been approved in the U.S. has that black box warning. So people should not be alarmed when they see it. It's just put there that babies are at risk for essential fatty acid deficiency. So, so if you see it, you look at all the, nobody reads package inserts for old drugs, but it's on all of them. The way they brought it in as 1 liter bags, and I don't understand that. It had to be filtered, but now we know all lipid emulsions should be filtered. If you look at the new guidelines, you probably are all using a filter on your sets now. But unfortunately, for reasons I don't know to this day, it never became available in the U.S. They got it approved, but they never sold it. Now, SMOF came out a year ago around this time, but it's been in Europe since 2000. It's not new. It's new to us, but not new to Europe. It's a blend. It's a blend of soy, MCT, olive, and fish oil. I saw the launch at FASPEN. I think it was in Glasgow back then, or Lisbon, one of the FASPEN meetings. It was based on the Mediterranean diet. The way it was marketed was it's the Mediterranean diet, it's perfect balance. And that's how it wasn't made on therapeutic claims at all. It was just a matter of balance. It has all the anti-inflammatory aspects, the immunoprotection, the pro-oxidant properties. So they figured it might be better in critically ill patients who don't need all that pro-inflammatory omega-6. But again, in Europe and Asia, they can make different claims than we can make in the U.S. market. So you might, if you look at European literature, you're going to see that they use it in a different way that we may use it in the U.S. or the way it's sold in the U.S. And when they also looked at it, they looked at the fatty acid profiles of SMOF to like breast milk. So in Europe and Asia, they use it in children because it has similar fatty acid profiles as a breastfed baby. So in that situation, if you look at the European literature, you'd feel comfortable using it in children because of this literature that they have. The current approval is only for the adult population. Again, as a source of calories and essential fatty acids, nothing else. No special patient populations or anything. It's just approved on that, non-inferior to intralipid. Pediatric indication, currently not FDA approved for pediatric patients. That being said, 80% of the meds I dispense at Boston Children's are not FDA approved for kids. And I know for a fact many of the kids in this room are getting SMOF today. So, I mean, that doesn't stop you. It's just that the manufacturer cannot market it that way. They can't put pediatric dosing in the package insert. They can't put promotional literature out there saying what pediatric information's there. You'd have to go to a special kind of sales rep called a medical science liaison, or you go to the primary, have the pharmacists or the physicians go to the primary literature to learn more about it. So it makes it a little more difficult for people who are trying to treat kids. There are, as part of the approval process, they had to do some what's called post-marketing studies after the drug has been in the marketplace. There are some studies ongoing right now. Many of you may be aware of it, that they're doing it at different hospitals around the country, comparing SMOF to intralipid in pediatric patients, and they're looking at different outcomes. The one thing I can say is SMOF is not suitable for that lipid-restricted dosing that we've seen with intralipid. Some people, when we started seeing that lipid emulsions might be bad for the liver, we started reducing the dose. However, you can't do that with SMOF, because SMOF already has less soybean oil in it. When you think about it, a gram per kilo per day of intralipids equivalent to around 3 grams per kilo per day of SMOF. So you want to use SMOF the way the manufacturer wants you to, as opposed to the way we do things off-label, like with intralipid doing the low-dose approach. It's not suitable for lipid restriction. So what's still investigational? Omegaven is still investigational. When I came here back at the Cape back around over 10 years ago when we first talked about this, we thought we were going to have it approved by now, but it still isn't. It's approved in Europe. It's a pure fish oil emulsion. It was marketed to be mixed with intralipid. The dose that the manufacturer came up with was 0.2 grams per kilo per day. When we use it to treat liver disease in children, we do a gram per kilo per day, and we do not mix it with intralipid. There's no pediatric indication for either in Europe or, and it's not to be designed to be used as monotherapy. And we do it totally off-label this way under a compassionate use protocol. Still not FDA approved, although things are moving slowly. The data is being collected to be submitted. We first used this in 2002 to treat a patient who was totally allergic to soy. And when this is the only soy-free lipid emulsion anywhere in the world. It's still the only soy-free lipid emulsion anywhere in the world. He had essential fatty acid deficiency. It treated the essential fatty acid deficiency. So again, it was a proof of concept. We knew we could use it as monotherapy and not get patients deficient. We subsequently used it to treat liver disease in children. We've published it in pediatrics. We stop all, in our protocol, and it's like I said, it's a compassionate use protocol. You have to have pre-existing liver disease. You can't use it to prevent liver disease currently, the way the FDA has our protocols approved. So you stop the soybean oil, you switch to Omegaven at a gram per kilo per day. For the rest of the time, you're on parenteral nutrition, and you make up for those loss of fat calories as carbohydrate. And if you ask me why we haven't used SMOF to treat pre-existing liver disease with the SMOF instead of Omegaven, which is approved, SMOF being approved, we always go back to our animal studies. This slide just shows you graphically. This is a chow-fed mouse. That's our reference standard. And we always compare the livers of the mice to a normal chow-fed mouse. Omegaven and chow are very similar. When we switch to the other lipid sources, such as intralipid, that's the worst. All that red is bad. Clinoleic, also equally as bad. That's why we never jumped to clinoleic when people offered it to us. And when they were offered SMOF, it's kind of an in-between. If you have pre-existing liver disease, we wouldn't want to treat with that. You might want to use it to prevent or use it at a patient population at risk. But if you already have PN liver injury, because of this data we have in animals and as well as case reports from Asia, we probably wouldn't recommend using a SMOF blend to treat pre-existing liver disease. But again, this is all off-label. So in summary, the products that were approved are only approved for adults. No matter what you may think of my biases, I still don't think we have a perfect lipid emulsion. I could tell you flaws about all the products if you wanted me to. We've made progress. Like I said, we've had 2 different products approved in the U.S. in this millennium, but we still have a long way to go. And of course, I can't do this alone. We have the lab with Mark Puta's lab, and we also have the care center. They have a table out there if you want to say hi to them. There's a bunch of our team members here, but it takes a village to treat all these patients. And without all of them, we'd not be making any progress. So thank you.
Okay, I'm going to get tough. We can take 2 questions, make them good, and then we're going to defer everyone to the breakout session this afternoon. Oh, pick your favorites, Bob.
So people with pre-existing allergies such as fish, seafood, would they be, what kind of lipids would you recommend for them specifically?
Okay, well, that's going to be a challenge. I don't want to know what the nature of the allergy was, and that's why you talk to an allergist, because it's, sometimes allergies aren't allergies. It might be an intolerance. So you'd want to get a real, an allergist involved for the, if it was truly an anaphylactic reaction. Like my soy allergy patient, we tested him with intralipid, he anaphylaxed. He would have died if we continued onward with him. So they'd have to evaluate that. You'd be stuck with soy if you truly were anaphylactic. You'd have to, again, I would never do this you'd get an allergist involved.
Kathy, one thing that's not really a question, but a comment, because neither of us, you're not old enough to remember this. I probably am, but I wasn't doing this kind of thing then. Was before intralipid was approved in the United States, what they did was slather topical oil on the adults and children. So whoever does the laundry at your house would really probably shudder to hear this. But that's how they got their lipid back then.
Yeah. Actually, I didn't get into that, but our soy allergy patient, we did try that, but he had really bad skin issues back in the day. We still did it with kids who were intolerant to lipid emulsions. Babies and isolators would burn because they'd be coated with oil. And you'd put them under warming lights, so you'd fry the baby, literally, if you weren't paying attention. So not a good idea. So that's another reason why it's good that we have choice now to get different products.
Okay, Kathleen, thank you so much, and she will be hosting 2 breakout sessions this afternoon. She is the oil woman. Okay, I invite our next 2 speakers, who are the advocacy king and queen, Bettemarie Bond and Kendall Van he's here, Kendall Van Poel. You're supposed to walk her down the aisle, Kendall. That's what I was counting on anyway. They need no introduction, but I'll have them tell you a little bit about themselves and then get right to business.
Keep talking? All right, we're good to go. All right, thanks everybody. And thanks to Oley for having us here. This is great. I've been very excited about what we've seen today already with the research that's going on. I'll say this is my 2nd conference. I'm Kendall Van Poel. I'm with the National Home Infusion Association. And for anybody who's watching online, you really should come. This is a very good conference, and you learn and meet a lot of people. And so I have to say thank you. And I have to do also a little bit of a plug for the both of us. We're going to be quick on some of the things that we're going to talk about today. Policy and advocacy can get weedsy and deep, but we're going to skip across the top of the lake here, talk about some of the issues that are in front of us right now in Congress and how to be good advocates. So if there's anything that you missed today, want more information from us on, NHIA, we have our own table here so you can come by and talk to me. We also have a set of breakout sessions tomorrow afternoon. So if you're interested in advocacy and really kind of diving in on what we talk about today, know that that opportunity is there for you. So without further ado, we'll kick it off. We'll talk through some things, and then I'm going to turn it over to Bettemarie to talk through really how she's done things. Because I think that it's a little more important to hear from one of your own who's made a real difference in Washington, D.C. I can't thank her enough for everything that she's done. So myself, what I'm going to say is we need people like you in Washington, D.C. Interestingly, I was in the back of the room and somebody turned to me and said, "Are you a salesman?" And I said, "Well, kind of. I'm a lobbyist." But that's actually, that exchange that I had tells me exactly what you need to hear. People in Congress can hear from me. I know about policy. I know how Congress works. I know the ins and outs of parliamentary procedure and all those kind of things. But for them, what's important is the people that are directly affected by whatever issues in front of them are the most important people to be talking to. So if a senator said this at a conference that I was at, and I found it very poignant. If you shut up, you're shut out, because people just aren't going to know on Capitol Hill what your issue is and why whatever you're working on is important to you. So I'm going to let Bettemarie cover more of that in just a second, but I wanted to make sure that that was very clear, that it's important that you go up there. You don't just rely on people in suits like me to do the work for you. It's important that